So welcome to the Research into Practice webinar. This is the 5th of November slot for JUICE, which is our Youth Mental Health Research Unit, and we'll be looking at physical health in inpatient CAMHS. Thank you so much for making time for this session. My name is Emma Wilson. I'm the Communications and Engagement Officer for Research and Innovation at Greater Manchester Mental Health. So I will shortly be handing over to our speakers today, who are Professor Sophie Parker, who's a consultant clinical psychologist at GMMH, a professor at the University of Manchester, and the director of the Youth Mental Health Research Unit, JUICE, and Dr. Rebekah Carney, who's a clinical research fellow and trial manager at JUICE as well. Without further ado, I'll pass over to you, Sophie.
Thank you so much, Emma. Lovely to see so many of you today. Lots of familiar names and lots of new names, which is really lovely. So big welcome to hearing about us. So for those of you who don't know who we are, so I'm just doing one slide to introduce you to the JUICE Youth Mental Health Research Unit, named JUICE, much bigger talk, but by the young people who are part of our PPI work that we do that's embedded throughout the youth unit. And you can see here our mission is to really ensure that young people have the opportunity to take part in research and have the opportunity to access evidence-based treatments, and that we develop those. And really important and related to this talk that they're very much applied within the services and the areas in which we work, so that we're serving our own communities and also really learning from those communities, because there's a high likelihood that in an applied research way, as opposed to in a university setting, we will see that really applied really well in terms of what we can learn from those who are accessing treatments and services. What you're going to hear about today fits into some of the portfolio of work that you can see in that middle area described on this slide. So the physical health work that Rebekah leads on. We work in a number of other domains around at-risk mental states, psychosis, bipolar, and we particularly ensure that we have youth voices very much embedded throughout our research. You're going to hear a little bit about that with Beck, and really thinking today in particular about that integration aspect of our work, feeding back to teams, feeding back to services, and likewise hearing from you as to how you feel this could be applied, what the barriers are and challenges that might offer new research opportunities. So I'm not going to spend any more time on that. The main thing that you're here for is to hear about Rebekah's fantastic work that she leads on around physical health, and particularly in inpatient CAMHS, which is such an needed and important area. So over to you, Beck.
Thanks, Sophie. So I'm going to try my best in the limited amount of time that we've got to do a bit of a whistle-stop tour of some of the work that we've been doing, focusing on physical health for young people who are receiving CAMHS inpatient care. So I'll start off with a little bit of background as to why we're doing this work in the first place. We know that people who've got serious mental illness experience significant physical health inequalities, which result in a totally unacceptable and largely preventable 15 to 20-year premature mortality rates. A lot of these physical health problems tend to begin at a very, very early stage, often beforehand or alongside the emergence of mental health difficulties. And most physical health problems that do occur tend to persist then into adulthood, and that are much harder to address and to treat. There's lots and lots of factors, which is, again, as Sophie kind of alluded to before, that's a whole other talk in itself. So I'll just deduce them to just a couple of examples. So things like adverse health behaviours, so not being able to get enough exercise, not consuming a healthy diet, engaging in adverse health behaviours such as smoking, alcohol and substance use, all have an impact on people's physical health, both short and long term. Lots of issues around side effects of medication. So whilst the medication might be really useful and therapeutic to people, we know that it comes with unwanted side effects, particularly when in relation to metabolic health. There's factors around the environment, so whether that be a CAMHS inpatient environment, an adult inpatient environment, whether that be where people are living and what they've got access to in the home and around the home. And we know environment plays a massive factor in the development of physical health problems long term. And And then we also know that there's a big issue around inadequate monitoring of physical health and mental health services. So things like diagnostic overshadowing, where conditions are kind of left untreated or maybe associated with people's mental health conditions. All of these factors kind of, accumulate into a bit of a toxic storm, really. And then when we really think about the inpatient unit in particular, it tends to get use this term obesogenic environment. So whilst it may be, again, on a similar note to the medication, really therapeutic for someone's mental health recovery and well-being, and it tends to be, quite obesogenic, so can have a really negative impact on people's physical health due to lots of factors. So mainly being around like a restrictive environment, and I think we've kind of all felt that throughout the pandemic when we were all confined to our homes in these really small spaces where we're not getting very much incidental activity, unless you're doing Joe Wicks in front of the TV all day. It's kind of everyone's physical health kind of had a bit of an impact and a bit of a knock from that. So when you add that factor into an inpatient environment being really restrictive, combined with lots of these other factors, we know that it can be quite obesogenic for young people. And then we also know that the early intervention leads to better preventative care. So if we can get these things early, address them early, primarily before anything develops into a long-term condition, it allows better preventative care in the future. But what we do know is a lot of this research has been done with adults, and there's relatively little that's being done with young people, with a young person's focus. So what we've done over a number of years is we've conducted some systematic reviews, looking at the literature that's already out there, looking at cardiometabolic risk. We've also looked at any interventions, whether interventions have been conducted on inpatient settings for young people. Quite surprisingly, there's been not very much research conducted, in contrast to the whole wealth that we've got for adult research. And we started quite small as well. So we've done some local audits of our GMMH services, looking at routinely collected physical health data, and all of these papers are available for access, or if anyone's struggling to access, I can share them and talk about them in more detail if it would be of interest to anybody. We've also done some qualitative work previously as well with service users and with staff on our GMMH CAMHS inpatient units. And I think the quote really speaks to what we found, is that if you're struggling, you don't really care in relation to people's physical health. So when young people are coming onto a mental health inpatient ward, if they're struggling with the mental health, the physical health kind of takes a bit of a knock. And we found some really interesting things, which I can obviously speak to anybody about if you are interested outside of this talk, and share the findings of that. But really interesting factors around like all of the things that are affecting young people's physical health when they're receiving treatment. But essentially the take-home message is that it's really complex, and in terms of the research, there wasn't very much that's being done longitudinally. And what happens to people's physical health when they get admitted to an inpatient ward, and then again over time, which leads us to the Y Health study. So it was a physical health study of young people on inpatient mental health services, a 6-month prospective study. We've done this across 3 different NHS trusts, so here at Greater Manchester, over at Leeds and York, and also at the Humber NHS Teaching Foundation Trust. It was conducted between 2021 and 2023, so unfortunately that did cover both COVID-19 pandemics, multiple periods of lockdown, so it was really tricky to actually deliver the study to the kind of like the capacity that we really wanted it to, and we had to adapt it really quickly. But I can speak to anybody about any of those adaptations that we made throughout the pandemic. But it did really mean that we had to pull on the resources of the clinical teams when we weren't actually able to go onto the wards to conduct the research. Our overall aim was to explore the physical health of young people admitted to the inpatient units over 6 months, and we wanted to do lots of exploratory work with this study. But essentially we wanted to kind of establish the feasibility of looking at people's physical health upon admission and then over time, because it just seemed to be something that hadn't really been done that well before. The method, so we recruited young people aged 14 and above admitted to CAMHS inpatient units across the 3 participating trusts within 6 weeks of admission to the unit. They had to have capacity to give informed consent and be well enough to take part, which was assessed by the clinical teams. Again, another example of how we worked quite closely with them. And anybody that had severe anorexia or an eating disorder, which would have meant that it wouldn't have been conducive to their mental health recovery, were excluded from the study. We done physical and mental health assessments, which were completed by a researcher, or if the researcher wasn't available or wasn't able to go onto the inpatient unit, we used the clinical teams as well to help us with that. And we've done that at 3 time points. So that was baseline within 6 weeks of the person being admitted to the unit, 3 months after, and 6 months after again, regardless of whether people have been discharged to the community, whether they, have gone over the age of 18 and they transitioned to adult services. And we tried to follow people up as best we could. And then we had an optional qualitative interview as well. We collected a whole host of different measures. So we looked at lots of demographic factors. We looked at lots of physical health checks. So things around like BMI, blood pressure, blood tests, whether they were collected, and any results of those, any health behaviours. So we looked at people's physical activity levels, whether they were being sedentary during the day, levels of sleep, whether people were classed as smokers or not, anything that the young people were eating over the past 24 hours to give like a bit of a proxy measure of the diet and the dietary intake, fitness, substance use, all kinds of behaviours that affect people's physical health. And then we also collected 2 kind of routinely collected mental health measures, which the young people were familiar with completing as part of their routine inpatient care, but we administered those as self-report questionnaires. So we collected the HANOSCA and the World Health Organization Wellbeing Index. So a bit of an example of how we worked with young people on the study. Prior to when we were actually in the setup phase, we had lots of PPI input as to the words and whether it made sense, whether the information sheets were clear about what young people were expected to be doing, and then we actually started the study, and the feedback that we got from the young people who were on the wards were that it just looked really dry, really boring, and it made essentially just no one really wanted to take part because it looked so crap basically. So we got them involved with designing it and making it look a little bit more appealing, and they wanted it to be quite visual. They wanted to, generate lots of graphics to actually visualize what the study meant, which is how we came up with all of the branding. So we worked really well with a graphic designer that we work quite closely with, and the young people to develop all of the branding that goes alongside not just the Y Health study, but then we use it throughout all of our physical health work as well. And then just some of the key findings. This is the consort. So what we did notice is that admissions were significantly lower than before the pandemic, which we based our kinds of recruitment targets on. There was a big change as to inpatient admissions throughout both periods of lockdown, and there was considerably fewer young people that were admitted to the ward. So we were looking at a baseline of a lower amount of potential participants when we got started. We ended up recruiting from all 3 NHS trusts, and we recruited 27 young people. Just a bit of a slide, just giving an overview of who we recruited. Again, mainly from Greater Manchester, but we did recruit from all 3 trusts. Participants were mainly female. The average age was 16, and the ethnicity was mainly white British or white other, which was representative of the young people that were on the wards at the time. In terms of retention, so we didn't really get that many people that decided that they no longer wanted to take part, but what we did find was really interesting that in terms of their engagement dropped significantly throughout the course of the study over the period of 6 months. So whereas we could still make contact with young people and they were still quite happy to receive phone calls, and we could still follow people up, they were actually really saying, I don't really want to come back in and do these physical health checks, or can I not just go to the GP? Can you not get it from my CAMHS records? And what we were finding is that quite often the physical health data wasn't there for us to even be able to supplement it with if the young people weren't then willing to then stay engaged and do the physical health checks at the 6 month time point. So we are going to look into that a little bit more and do some more PPI work as to how we keep people engaged once the young person's been discharged. We did find that when people were still on the wards, it was more likely that we could collect the data out. So it was more likely that they were, one, willing to provide us with the additional information at 6 months, but then also if they weren't willing to provide it and weren't willing to do it, it was more likely that the physical health checks had been done as part of routine monitoring and inpatient care, whereas in the community it was a little bit more vague. This is just a slide showing that kind of varies over the course of time. In terms of the diagnosis of young people, it was for most people, it was their first admission to an inpatient unit. Even if they'd received previous mental health care, it was the first admission to an inpatient unit. Mainly diagnosed with mood disorders or disorders associated with stress. Something to note as well is that diagnosis varied over time, and quite often some young people will come in and they wouldn't necessarily be given a diagnosis because it was their first inpatient admission, and they were undergoing ongoing monitoring, assessment and formulation to result in that diagnosis, which is probably why we could see that variation over time. Medication at time of admission, so there was quite a lot of polypharmacy, so young people receiving more than one medication on admission. Half the sample were in receipt of antipsychotics, half the sample were in receipt of antidepressants. Again, this is at admission, so this isn't over time after following diagnoses. This is all upon admission to the inpatient unit, and these aren't mutually exclusive, but there's a bit of overlap with these. So some young people might have been receiving 2 or 3 different classifications of medication. One of the most stark findings that we did get from this study was this significant increase in weight over time. So pretty much every young person that took part in the study, and we had follow-up data for, gained weight over time. And as you can see in the graphs and the chart shown on the slides, it is a significant increase in weight. So an average of 5 kilograms of weight gained within just that really short period of 6 months. It's again centiles, they're increasing significantly, going from just over 60 all the way up to nearly 70 on the BMI centiles, which we use because obviously the sample's under the age of 18. And in terms of who was classed as overweight or obese, that rose significantly over the course of the study as well. Unfortunately, the numbers were too small for us to be able to see with any kind of significant statistical significance if that varied compared to people that were discharged or people that remained on the inpatient unit, but that's something that we'd like to look into in the future. This is just reiterating what I've mentioned on the previous slide. So just in terms of like the sheer difference in weight and body composition over time. And another thing which we didn't really expect, given the fact that the young people were, they were so young, a sample aged between 14 and 18, is that 44% had a recorded or diagnosed metabolic condition at baseline, and quite often this is the first time that it had been picked up. So it was things like diabetes or dyslipidemia, and there was lots of other risk factors for metabolic ill health. So quite a lot of young people might have had evidence of tachycardia, elevated blood lipids, increased blood pressure, all of which were picked up at the routine physical health checks, either our researchers conducted at baseline or that were conducted as part of the routine admission process. So as you can see, it kind of remained stable over time in terms of metabolic conditions, but really high rates for such a young sample. And then just touch on some of the other findings from the assessments that I kind of mentioned before. Really persistent low levels of exercise and physical activity, relatively poor dietary intake, so things like not necessarily in really structured meals, so often skipping meals, 1 meal a day, lots of snacks. Emerging physical health risks, as I've already mentioned. There was issues with cognitive impairments and concentration, which then affected difficulties engaging with education, low levels of self-reported fitness, and as you would expect, really high levels of low mood and anxiety, high levels of self-harm, and quite frequent impaired relationships with others, whether that be peers, family members, guardians, or anybody else involved in young people's care or like kinds of social circles. I don't really have much time to talk about this today, but I'll just give a really brief overview of the qualitative study. So we've done interviews with 7 participants across all 3 sites, and the real aim of this was to understand the impact of the inpatient environment on lifestyle and physical health, and really understand the young people's experiences and beliefs about their physical health care on the CAMHS inpatient units. So these are just some of the emerging findings that still needs refining a little bit more, but some of the really interesting things that have been coming out relate to things around sources of support. So one of the things that we did find is that young people it's quite unsurprising that they would go to places like TikTok, or they would, go online and social media to find out things about the physical health. So that's not necessarily that unusual given the young age of the sample, but what is unusual is that they're residing within an inpatient environment. So as opposed to seeking out that information from a health professional who may be walking backwards and forwards, past their door multiple times a day, or who may be physically present on the ward, they're actually not accessing that physical health care as best as they can. So yeah, there's definitely some more work that needs to be done there in terms of where young people are accessing information and ways of kind of coping and improving the physical health. And then there was also lots of stuff around monitoring, and the general take home was that young people weren't really too bothered about physical health monitoring. They thought it was quite a good thing. They thought it was quite useful, and yeah, in terms of the actual assessments, despite what we were finding when we were trying to follow people up, and they were saying, oh no, I don't really feel up to coming and meeting you again, and I don't really fancy coming back to the ward to do a physical health check and do an assessment. I'm quite happy about living my own life. It may not necessarily be anything about the actual physical health check itself, because the young people didn't really feel like they didn't really have much of an issue with that. So I don't know if there's something that needs to be done in terms of communication and working with staff a little bit more. But yeah, some really interesting things, which again I can speak to you about if that would be something that you'd be interested in hearing more about at another time. So just the general clinical implications, and what we did find is some worsening physical health trends. So we showed increased rates of overweight, obesity, metabolic risks, and consistently poor physical health behaviours over time. There was lots of challenges with physical health monitoring. So what we did find is that monitoring of physical health in CAMHS is often inconsistent and overshadowed by mental health priorities. So not necessarily in just the inpatient services, but thinking about when people are discharged to community services as well. And lots of barriers post-discharge. So what we did find, even just trying to arrange appointments with young people, is that care post-discharge just showed kind of poor continuity and decline in physical health data collection. So even young people that might have been put on antipsychotic medication for the first time and then discharged, with a relatively short stay, the monitoring, there was no clear guidance as to who was then responsible for monitoring that young person's physical health and conducting those checks. So there's just definitely a little bit more work that needs to be done in relation to post-discharge care planning. And a need for systemic improvements as well. So we often found that staff lack the confidence, training and time to address physical health needs, which does highlight the need for some more systemic change. And then just some calls to action from what we've deduced from this work and from the rest of the programme of work that we've been doing, is that there needs to be more rigorous routine physical health monitoring for young people. So really embedding these checks of physical health, of weight, metabolic markers, fitness into standard practice. And I'm quite pleased to announce as well that if you haven't heard of it already, the LESS tool has had an adolescent adaptation. So our colleagues David Shires and a lot of other people have been working on this for a number of years. So this is now being rolled out with support of the Royal College of Psychiatry, which is fantastic, and hopefully that should address some of the routine physical health monitoring barriers that we have noticed. We do also acknowledge that there needs to be some more enhanced staff training, so introducing dedicated physical health champions could be one way of doing this, and targeted training to improve staff confidence and the ability, and providing the resource to allow for that care consistency, taking into account both physical and mental health. Co-designed interventions. So as always, and at the heart of everything that we do at Juice, we believe that it shouldn't just be individuals who are sitting, academics or clinicians or researchers. It also needs to involve anything that is designed, needs to involve the people that are going to be using it and the people that it's appropriate for. So engaging young people, families, and also staff members, like I've already mentioned, getting everybody involved to make sure that any interventions are appropriate for young people. And then again, as I've already mentioned, strengthen discharge planning, so involving everybody that needs to be involved, so paediatricians, GPs, clinicians who work on the ward, to create these clear pathways for ongoing physical health care and treatment post-discharge. So just a bit of a thanks to everyone that was involved. So our collaborators and research team. So it was a collaboration between the NIHR, our Greater Manchester and Yorkshire and Humber. We had lots of PPI contributors that have helped and continue to help us with this work, which we couldn't have done it all without. And the clinical teams and support staff. So as Sophie has already mentioned, this project itself was a real collaboration between us and the clinical teams, and it wouldn't have been possible without having that buy-in from the clinical teams. I didn't really mention it in the slides, but some of the things that we did do were, getting junior doctors or people who were on placements, trainee psychiatrists were all integral to making this study happen, being part of that process of assessing young people's clinical risk to see whether they were actually able to provide that informed consent, whether the study would be appropriate, and having those initial conversations on the wards. And we wouldn't have been able to do that without the support of the clinical teams. And then obviously our funders as well. So we acknowledge our funders, which were the NIHR, in collaboration with our NHS Greater Manchester Mental Health Trust. And thank you for listening.
Fantastic. Thank you so much, Rebekah. That is the first webinar presentation that has run exactly to time. So very impressive. Thank you. We are now going to move on to the Q&A section. So one of the first questions we received was, were there any interventions being implemented to support educating young people about their physical health, such as groups or focus sessions?
So as part of this study, we didn't design or implement any additional interventions. The purpose of it was solely to track people's physical health and to see what happens in that naturalistic inpatient environment. As part of the routine inpatient care, we know that there's lots of fantastic work that is being done. So there was lots of work from occupational therapists. There was different events and different kinds of groups that we're running as part of routine physical health care on the inpatient unit. But what we have found from previous qual work is that can be quite inconsistent at times. So it may be that, a certain staff member's there and is really, really engaged, and then that person leaves and they've got like a smoothie group that's has been running for like 3 months, and then all of a sudden that doesn't run anymore because that staff member's left and they're waiting to fill the post. So considering that the study went on for quite a while, there was lots of different intervention, but there was nothing really there was nothing that we implemented as part of this study anyway.
And I guess a sort of supplementary question from myself is there somewhere that you'd like to take now that you've got the findings of this study, where you're kind of maybe looking for the next step after this?
Yeah, so the aim really is to secure some future funding so that we can develop the interventions that are appropriate, pulling on everything that we've learned, so from both qualitative aspects and from the monitoring study that we've done, the Y Health study, and everything previous. And what we really hope is we want to try and develop an intervention that's appropriate, but for young people and for staff on CAMHS inpatient wards. But not only that, where they can engage it while they're on the wards, but also something that translates out to community care as well. So we're hoping to be able to obtain some funding to be able to do that in the near future.
Another question we had was from someone who says, I work in inpatient CAMHS in GMMH, so I'd like to get involved. That's not a question, but that's fantastic, and we'll address that later. My patients tend to have long admissions in the unit, so their physical health does become a factor to be reviewed on a regular basis. I work alongside, this is more of a comment than a question, but maybe there's something we can pull from it. I work alongside our wonderful physical health team comprising of our visiting GP and physical health nurse. That's someone who works in adolescent forensics. Have you got any thoughts or comments based on that comment about physical health?
Yeah, so I think again that's something that we found from doing this work is that there's lots of fantastic work that is being done, but it's just not out there for people to know and to learn from. So it's definitely something. I mean, whoever it is that said the comments in, I'd love to link up outside of the session anyway, and just see if there's anything that we can do just to kind of evidence any work that is being done at the minute, and be able to translate that onto a more a wider scale, because there's lots of brilliant work that's being done in of physical health promotion, but it tends to be done in pockets of places, as opposed to a lot of the adult literature. You know, there's a lot of big randomized controlled trials, and it's published quite widely, and you know, this intervention really works, and do this amount of steps a day, and you know, your heart's going to be however many years younger. But in the youth research field, there doesn't tend to be so much that's done. So any examples of anything that is being done that's good practice, I think it's really important that we share that.
Fantastic. And would you go a slide back so that we can have your contact details again, just in case that person wants to catch them? So we've obviously got the GMMH email addresses for both Sophie and Rebekah there, but there's also YMHRU, so Youth Mental Health Research Unit at gmmh.nhs.uk, which is a mailbox that the whole team can access to answer you. So yeah, I think that is a really key point that comes out of this, is that we want it to be an ongoing conversation, and we'll touch on that near the end as well, about how you can get involved and more in touch. So there's another comment here that was, the average wait for completed appointments is 17.59 weeks. Despite best efforts to reduce this time, waits are long in areas of Greater Manchester. How can the waiting time be reduced further, and what is the projected timeline for this? So much more about CAMHS generally than necessarily physical health in this study. But is there anything that we can answer or discuss on that question?
I think I will deflect to the clinician in youth and pass that one over to Sophie.
So there's nothing particularly specific in our unit, but there's some really fantastic work that particularly sits in the Applied Research Collaboration, ARC-GM. So they've got some fantastic studies looking at the certain aspects of CAMHS waiting times and innovative ways to develop more quick and effective access to treatments. And also one of our other colleagues who works in the digital research unit, Rebekah, is running a trial currently for young people on waiting lists who have experiences of depression. So there's lots of other, I guess there's multiple things there, something about research opportunities, both for young people on waiting lists and linking people up to perhaps some of the other talks that they might be able to access through ARC-GM and other collaborators and partners around really interesting ways of navigating the sort of waiting list and demand that we're currently seeing, and much higher than we saw prior COVID. It's even worse, and it was bad enough before. So and happy to put people in touch with a variety of people that would be really good to hear from and listen from in that sort of area and domain.
Thank you very much. We did have a question through on the Q&A tab saying, could we share the details of the new physical health monitoring tool? I've posted a link as a comment under that to the Leicester tool page, and it's page 5 onwards that discusses adolescents. We also have a webinar actually about the Leicester tool, more for adults, when it was the framework was updated, that David Shires presented on last year. That's also on our YouTube page. Another question here, how can we find out more about the qualitative findings from staff and user and service users? Is there other ways that we can hear about the findings of the study?
Yeah, so I mean, I'd be happy to, if anyone wants me to come and give it like a bit of a overview of that, the study that we actually done, the qual study. I can certainly do that if it would be helpful to come into any of the clinical teams and do that, or I can come back to one of these webinars and do it at a later stage. The findings for the staff and the service users is published, so the link is available on the slides. But yeah, if anyone wants to hear a little bit more, I'm more than happy to share. The qual aspect of the Y Health study isn't published yet, but we're hoping that should be over the next like 6 months or so. So yeah.
Fantastic. And obviously this study is now closed, but is there any other ways that staff or their service users might be able to get more involved in research that GEUS is doing? Are there any studies recruiting right now?
So yes, we're currently got some really interesting work that's being exceptionally supported by our FCAMHS and Gardener Unit colleagues. Thinking about hidden voices within our forensic CAMHS sort of spaces and areas, and that particularly focuses on people from more marginalised communities and thinking about people's opportunities for accessing options for preventative care or treatments on their pathways. We know, for example, that in community services we have poor representation of people from UK ethnic minority backgrounds, yet in our inpatient spaces for adults and young people, that people from those backgrounds are overrepresented. So it's about hearing from really important key hidden sort of voices. So really, yeah, please do reach out. You can reach out on that generic email address. Would love to recruit more staff and service users for that study, and particularly to get people involved. But we're always looking, we've got multiple PPI groups, and they might have people in them that we have, for example, specific groups that are attached to specific studies. So we're in the follow-up phase of our bipolar at risk trial and have a specific PPI group for that, so people with lived experience of being having experiences of high and low mood swings, but also we have PPI groups, for example, people from UK ethnic minority backgrounds, young people who help shape a variety of our projects. They've mostly been working on BART because we've been running some inclusivity research strategies to try and get better representation as we're developing new treatments so that they're generalizable for our whole populations. But also for staff, it's so important that we work much more inclusively with staff to really understand some of the key issues that Rebekah's already talked about. So we know that there are such huge challenges. So one of the things that came to mind to me was when Rebekah was speaking about some of the physical health work that we know is done really well. I remember Mary at the time, the physical health nurse, just being pulled into so many different directions. So, you know, you get employed to do a thing on the inpatient unit, and then actually you get diverted into supporting the flu injections that happen during this sort of winter season, or a variety of other things. And I think it's calling the organisation to account to say, if this is a key priority and is really important, then we need to ensure that that resource stays and is invested. It's such a specialist skill, and it's such an important area. But actually, as we know in services, people get pulled into multiple directions. So I think working much more closely, perhaps with staff groups as their own PPI group, would be really important as part of our major key stakeholders, and that would be really something we'd love to hear from more people who want to get more involved. And also lots of opportunity for research placements or other opportunities for people to come and observe what we do or learn and share their expertise and learning with us. So we're more than happy to talk. You can tell from both Rebekah and I, we're big talkers, but we've also got big ears as well. We're very happy to listen. So yeah, that's just some of the other things we'd like to get people involved in.
That's superb. And I think that, you know, just being able to introduce the research unit like this and, you know, show that we're all human beings and colleagues trying to work together and achieve, you know, some really important goals and improvements, and encouraging people to get in touch and collaborate. I think that's fantastic. So thank you both very much for doing this presentation today and answering these questions. I know that there's been some comments about the Bay trial that was mentioned, and there's been a link put onto the Bay trial's website as well there. So thank you everyone for sharing. This is a shameless plug for research and innovation at GMMH overall. We have 11 research units in our department, 130 staff working together to try and achieve an awful lot of different things, whether that's pharmaceutical intervention, observational. There are so many different things going on. We try and share them where we can on the internet, on the news pages, the webinars like this, but we've also got social media accounts where we post about publications and upcoming events. We have an Ask About Research mailbox where if you're not really sure who to ask the question to, but it's research related, we'll find the right person to answer it for you and get you in touch with them. And of course, our website, which has a great tool called the Active Studies Finder. So that's got about 50 to 60 different studies that are open. Most of them are recruiting, and you can find out, are your service users applicable or suitable for these? Maybe you can refer them in. Sometimes it's ourselves. There's some studies that just ask for a saliva sample, and you can send that off and help try and figure out if there's any genetic links to certain mental health issues. So do give that a look and a browse, and there's ways to get in touch with those teams if you'd like to get more involved in a variety of different ways. But thank you so much for your time on a Wednesday afternoon. Thank you so much, Sophie and Rebekah, for sharing about why health and juice generally. And I hope that we can continue the discussion offline or on email, and hopefully in a future webinar as well. We've got a few lovely comments coming through as well, thanking you for a really great presentation. So thank you, everybody. Have a great afternoon and see you soon.
Thanks, everyone.
Thank you. Bye.